So, dear Roxana, dear friends and colleagues, warm welcome to Heart Center Leipzig in our hybrid OR. It is our pleasure to share with you in the following transcatheter edge-to-edge repair tricuspid valve using the Pascal device. I have with me my dear friends and colleagues Christian Besler, cardiologist, Sergei Leontiev, cardiac surgeon. We have with us Kamim Bevilacqua. He will guide us through the procedure during the TEE, and this procedure is all about imaging, as you know, and as you will also see. And then we are also surrounded by a fantastic team. We have with us Annette, Silke, from Edwards. We have Leander, Heike, Diana, and some more. And Christian will take you right into the patient's details.
Sure, Philip. Dear colleagues, the patient we are treating today is an 87-year-old lady with a BMI of 26 kilogram per square meter. She was quite active until like 1.5 years ago when she experienced worsening dyspnea on exertion and pitting edema on diuretics. She's known for long-standing arterial hypertension and permanent atrial fibrillation. She's in advanced chronic kidney disease, has severe aortic sclerosis, and a history of breast cancer with radiotherapy in 2016. The cancer is currently in remission. Next slide, please. She's currently on vitamin K antagonist therapy. Congestion is currently insufficiently controlled by toracimide 40 milligrams and 25 milligrams of spironolactone. Next slide, please. So on invasive diagnostics, coronary disease was ruled out. Right heart cath revealed isolated post-capillary pulmonary hypertension with a cardiac index of 2.5. Transthoracic echocardiographic imaging revealed massive biatrial enlargement, particularly the right atrium was severely dilated. Systolic left and right ventricular function were normal, and color Doppler reveals severe tricuspid regurgitation. Next slide, please. On closer look at the tricuspid valve, you can appreciate that there is severe annular dilatation. However, there's almost no tenting, so the line of cooptation is nearly on the height of the tricuspid annulus, and the tricuspid regurgitation is almost over the entire cooptation line, going from posterior to central to anterior. Next slide, please. So altogether, this anatomic phenotype is compatible with atrial functional tricuspid regurgitation in contrast to ventricular functional tricuspid regurgitation in pulmonary hypertension or left heart disease. There is almost a normal right ventricular dimension. Sometimes you can see a slightly enlargement of the right ventricle at the very base. There is severe annular dilatation, but almost no tenting, and a severely dilated right atrium. Next slide, please. So altogether, considering the advanced age of this patient and her comorbid conditions, we decided to go for a transcatheter approach in this patient and to treat the tricuspid regurgitation by the Pascal system.
Thank you. So obviously functional TR, but not ventricular, but atrial, a condition which is actually very common, especially in elderly patients, in those with chronic AFib. It is associated with HFpEF, as we see also in that patient. And I think it's important to differentiate atrial as opposed to ventricular functional regurgitation because it has a different morphology and it might also have some implications for the treatment. Maybe let's go live into echo, have a closer look at the anatomy, and then we can have a discussion if you don't mind. So Kamim, please.
Yeah, thank you. Greetings from Leipzig. And as Christian and Philip already mentioned, the problem with this patient is the massive dilatation of the right atrium. So we have actually quite a big problem or challenge to produce the pictures that are necessary to facilitate the placement of the clip. So in this sort of short axis view, you can see the anatomy of the valve, and actually it's not only tricuspid, but you can see a small indentation in the septal leaflet, and you can also see an additional small leaflet in the anterolateral, actually anterior commissure. And I want to show you the pictures that I was talking about with the insufficiency. And as Christian already mentioned, we have an insufficiency over the whole area of the valve, so from the posterior to the anterior commissure and the central part also altogether. And I did a measurement of roughly 1.7 square millimeters AROA. The problem with this patient, as I told you, is to produce the pictures necessary for the placement of the clip. This is a sort of commercial view, but usually we can see the valve in this view, and as you can see already, it's difficult to produce the view of the clip and the valve simultaneously due to the movement of the heart. And what we can sometimes do to improve this is use of 3D echo in combination with multi-view, as we did in this case. So what we start with is just to acquire a 3D picture, and then we use this multi-view feature of the echo machine to position the axis in a way that we can see the clip and the valve in a perfect way. So let me just show this in a live placement here. You can try to...
Maybe we can jump to that in a second once again.
Yeah, okay.
Before we cross the valve with the Pascal device we're using here today. Any comments about the anatomy, the patient characteristics, and also maybe some advice with regards to the strategy here?
Wow, first of all, thank you, Christian and team here, and Philippe, for your wonderful, wonderful case, a very fascinating case. We have Lars and Nicholas and Kendra and David Hildick-Smith here, and I'd love to hear some comments. First of all, this is an unusual, not so unusual, HFpEF in an elderly woman, severe annular dilatation and an atrial enlargement. It almost looks like an Epstein anomaly if she was younger. I mean, you see everything pushed down, the right ventricle is working well, but she has a BMP of close to 2,000 and not responding, so this really should help her. I'm thinking you're going to need more than one clip, but let's see what others are saying. Kendra or Lars, maybe any of you, any comments?
Yeah, I can start. I mean, it looks like you need at least one clip, and probably also you'll still have quite a lot of TR left when you're done, but that's the nature of the game. Just one question, Philippe. I can understand you have difficult to have good images on this patient. Some sites will use intercardiac echo to try to optimize the imaging of the tricuspid valve. Is there anything you would suggest in a case like this?
I mean, we know that. Did you have quite some experience with that? We don't. We have to try our best to make TEE work. What we have here is we don't have very good esophageal views, but we have very good transgastric views, I believe. And at least if you have either or, you normally get away with it. And I hope we will do so today.
Yeah, and I think the key thing here is that if you're able to get from torrential tricuspid regurgitation down to moderate/severe, then you will make a big difference in this patient who's actually excellently chosen for this particular technique.
And Roxana, I didn't have much to add. They've pretty much summarized. I too was going to say, what about using ICE, as well as thinking that this is probably more than one clip. But I think the point here is you're not going to make it perfect. You don't have a technology that's going to make it perfect. But if you can reduce that torrential TR, you should be able to make this patient feel better.
Yeah. Philippe, is that your plan as well? Are you feeling exactly the same, Philippe? And then we'll ask Nicholas.
So the treatment goal would be to reduce it at least to moderate. That's for sure. I wouldn't be happy with bringing it down from 5 to 3. I really would like to see it moderate or less. The strategy in that case, I mean, you've seen that there is TR pretty much everywhere. But what we are going to do is, because we have very little tethering, and because we have atrial TR, we believe that we manage to use edge-to-edge therapy, obviously, but mainly not to treat the leaflets, but to reduce annular dimensions. And this is done by pulling over the RV-free wall in a hopefully quite compliant annulus, as in this case, towards the septum. And therefore, our strategy is almost disregarding of where we see TR, to replace 2 Pascal devices into the anteroseptal commissure, and thereby do that what's been working for centuries in surgery, reduce annular dimensions, and thereby reduce TR, not only at the site where we place the Pascal device, but also away from it more centrally and especially posteroceptally. Because what's clear, we can't place a device everywhere, but that would be our strategy, to place 2 Pascal devices. Pascal device is a nitinol-based device. It is very gentle to the leaflets. I mean, these leaflets, they're quite old. We want to make sure to be effective, but also be safe. We don't want to cause any injury to the leaflets. And what we can do with that device also, we can go for independent grasping or leaflet optimization, meaning that even if you grasp 2 leaflets at the same time, you can double check and maybe get an even larger bite of one or the other leaflet. So if you don't mind, we're going to start.
Yeah, you can start. I know, Nicholas, you wanted to make a comment, but yeah, Nicholas?
Yeah. Well, I think this is really becoming a very well-defined entity, this atrial functional tricuspid regurgitation, and we get more and more of those referrals to our hospital as well. And I think basically what you're aiming for, I think it's very appropriate to define your goals up front. And I think if your goal is for 0 TR, you're going to be disappointed. And actually what you're trying to do here also is you're creating a modified K procedure. You will turn a tricuspid valve into a bicuspid valve because you want to close basically that commissure, that anteroseptal commissure. That's basically what you're going to do.
Yeah. And I mean, there's some differences to mitral TEER imaging, that of course, but also the fact that we have 3 or actually more often 4 or sometimes 5 leaflets. And wherever you place your device, it is easy to distort the anatomy. And therefore, I'd like to stay within one commissure and don't make it too complex, but be as simplistic as possible. Okay. What's important before you cross the valve to make sure that you are in a almost perfectly orthogonal orientation of the device in relation to the tricuspid annulus. As said, because we have a quite distorted heart axis, this is in that case a little bit different in terms of echo views, but we can appreciate that we have a sort of 90-degree orientation on the right. That would be our long axis or grasping view. And then on the left, normally a bicommissural view where you have the aorta on the right and the anteroseptal commissure, and then on the left on the screen you have posteroceptal. Here it's a little bit harder to appreciate whether we are perfectly aligned, but we've seen that on the 3D views, and I think that's fine. We've also opened the device. We checked the clasp if we need independent leaflet grasping. And we will now cross the valve. I'd like to do that with the device being closed, just to make sure that I get not entangled anywhere. So we go through carefully, and then we ask Camille to move down with the echo probe to give us a transgastric view. What's helpful sometimes to get a transgastric view is to use also fluoro. I mean, obviously echo guides us, but we can also help echo a little bit. And when you combine fluoro and echo, then sometimes you will reduce the time to find a perfect view.
So, Philippe, you're going to grasp in a transgastric view. Is that correct?
Yeah, I'm not entirely sure yet. We have very good transgastric views. Not so good grasping views in the esophagus. I haven't decided on that. What we see now is that the device is in the anteroseptal commissure, so this is fine. Not right in the commissure, but between anterior and septal leaflet. We want to place the first 4 not too central, because we still want to have enough space to use to place a second Pascal device. By the way, we use the Pascal ACE device. That's a smaller device, 6 millimeter width. You see some motion throughout the cardiac cycle, but also related to breathing. So what we're going to ask now is to have a breath hold, please.
Yeah, breath hold is established.
I'll move a little bit into the commissure, and this is by advancing the entire system. Okay, so now I think now we are good. And then we will open the device.
Okay.
Okay, so we see the device open on fluoro, but not on echo, which is fine. I'd like echo to stay at the level of the line of cooptation. And now we move into the echo view, carefully and slowly. And then eventually, we should be able to appreciate the orientation of the device. The clocking should be really 90 degrees to the line of cooptation, which would be sort of 2 to 8 o'clock orientation.
Okay.
So we start to being able to appreciate the clocking. We're probably a little bit too much into the commissure, so I'll pull out a bit and try to go more central. Okay, quite a dynamic environment. So you see the device moving a little bit, but that's to be expected. Okay, now what you see very nicely is that the motion of the anterior leaflet has changed. The anterior leaflet is on the device. Can we get a second X-plane view here? Okay, so the anterior leaflet is on. What we could do now is we bring down the clasp of the anterior. We remembered which one it is. Okay, it's down. And now I move the system towards the septum. And if you can change echo views a little bit, then maybe it's here. Mm-hmm. Okay. Only view on the left, please. So transgastric large. We see the clocking isn't perfect. I have one leaflet in already, but I can still do slight adjustments to the clocking, not too much, obviously. Otherwise, I will distort the anterior leaflet. Okay. Not too bad. Maybe can we go, let's double check that on a esophageal view, if we manage to.
So now you're doing separate grasping, Philippe. Is this oftentimes, or do you most often grasp simultaneously?
What is it by now? 50-50?
Yeah.
It's probably 50-50. But what we very often use is, even if we've done it simultaneously, we do a leaflet optimization technique where we bring up one clasp, move further into the leaflet, and then get a bigger bite. Okay, so anterior is on. We see that. Septal is difficult to appreciate, so we have to change the view a little bit. That was to be expected, but here I guess we just have to be a little bit patient. And you.
So as you're working on this, I think we're gonna, if it's okay with you, Philippe, we need to go over to Erasmus. They also been waiting for us.
Can you give me another minute just to place this one?
I'll give you a minute. I'd love to give you another minute. I don't want to miss anything.
Thank you.
Please, go ahead.
Okay. So maybe let's go to transgastric again, because we don't see it well here. As soon as we see something transgastric, we will bring down the clasp and close the device, and then see what we get, okay?
Great.
Yeah.
Okay, so I think it's...
You can clearly appreciate that imaging is driving the procedure time. Huh? This is so important. You really have to see what you're doing.
Okay. So Christian brought down the clasp. Yeah. We will now close the device and see whether the two leaflets are coming closer together. Okay, I think that septal is in a little bit, but not good enough. No. We need to get much more, also to get annular reduction. We do that, and we show you once we are back.
Please film it all for us or something. Keep it for us. We really want to see it. All right, thank you, Philippe. We're going now. Let's go to Erasmus.
See you in a bit.
Hello,
Hey,
welcome back to Rotterdam. Hello.
Hello.
Welcome. So, welcome to today's live case here in Rotterdam. I'm here together with my friend and colleague Wijnand den Dekker, nursing staff, technician, and some supporting staff from Record Medical. We have lined up a renal denervation case for you today. I think a little bit, something different again. It's been a while since we have done these procedures live for meetings. But there's been a lot of interest in the past couple of years with a lot of accumulating data on the benefits and the efficacy of the technology. So we thought it would be good to showcase this in a patient with hypertension that was referred to us by a physician somewhere south in the Netherlands. So why don't we just start with the case description, Wijnand?
Yes, okay. Also, a warm welcome from my side. So we have this case for you this afternoon. It's a 70-year-old male with therapy-resistant hypertension. He has an active lifestyle, and his office blood pressure was 207/136 mean. So he has a long history of hypertension, more than 10 years already, and he has some organ damage also with that. He has hypertensive retinopathy, left ventricular hypertrophy, and some proteinuria with that. His BMI is a little bit high, 29. He had a gastric bypass in the past. He is known with a carotid artery aneurysm, and he has some sleep apnea, which is good under control now. So his ambulatory blood pressure mean was 160/102 with a good nocturnal dipping pattern. He had some signs of left ventricular hypertrophy on his EKG, and the echo showed good left and right ventricular function with a diameter of the interventricular septum of 11 millimeters. He had a good kidney function, but he had some proteinuria and albuminuria in his urine. The problem with this patient is that he is intolerant for quite some drugs. So now he is only on nifedipine, 30 milligram once daily. And the referring doctor already tried a lot of other medication which he could not tolerate well. So that's why he referred the patient to our center for renal denervation. So what we do in the workup for these patients is make a CT scan, and Victor will tell us something about this CT scan that was made.
Yeah, so hello everybody. I will today show you our CT scan. We do pre-procedural imaging in... We do pre-procedural imaging in all our RDN patients to assess renal artery anatomy, as well as to rule out some disease of the renal artery, osteal disease, renal artery stenosis, and also fibromuscular dysplasia. This patient has two solitary renal arteries on the right and the left without any signs of disease. And we also perform analysis of the diameters as well as the length of the renal arteries. Here on the right you see a 40.3 millimeters long renal artery, solitary one with a diameter of approximately 6.8 millimeters. On the left, we see a shorter solitary artery of 22 millimeters with a similar diameter on the CT scan. And so this is mostly, there's no accessories here, and this is that we assess the renal artery anatomy beforehand. Another reason to perform this CT scan is also to get the ideal projection for the angio during the procedure, which in this case will be perpendicular to the to both about 25-26 degrees LAO, which is also can be seen on the angio simulation as seen here. We did that. I'd like to give the word back to the operators.
Excellent, Victor. So Victor is one of the PhD candidates here who's working very closely with me and all the RDN trials we're running at the moment. So yeah, with that, this is the case of today. Maybe I'll stop here and ask you for any comments, questions at this stage before we dwell into the plan of today.
No, it's a great case. It's just nice to see renal denervation back up again. You know, I think some windows have opened for renal denervation. We're awaiting some really good results from the RDN program that's going to come up, and I think we're going to see some data at ACC. The RECORE program is a very interesting one. So what do you all think on the panel? Let's start with you, Nicholas. I know this is coming from your center, but do you actually see a revival, or do you think we just need more data?
Well, you know, Roxana, I have to deal with Jules on a daily basis, and we preview and do wrap-ups of all the major cardiology meetings, and every single time we discuss renal denervation studies. So at every major congress, there is renal denervation activity in the late breakers. So it has never been gone away, and I do have the feeling that it is gaining momentum again. And Joost is also involved in the design of newer studies, but it's, you know, it remains a challenge. I think one of the major challenges is also getting the hypertension community fully engaged in the discussion.
Yeah, and I mean, I think some of the data with the on-meds data that we just saw presented is really interesting, and how, you know, how you could combine this even with your medication and probably get the best possible results for hypertension control. David?
Yeah, I mean, I think for me, this isn't a procedure I do, but I think the idea of having a procedure which enables you to withdraw medication is something that's done in very many other procedures in the cardiovascular arena. PFO closure, left atrial appendage occlusion, stents. So, you know, this is a very worthwhile and laudable aim to try to revisit renal denervation and improve and sophisticate the procedure so that you actually get good long-term results, and hopefully then the patient can come off some of the medicines, which inevitably, of course, have daily side effects for them.
Yeah. Any other comments from the panelists, Lars or Kendra? What do you all think?
Yeah, I can maybe ask you, Joost. It seems that renal denervation is going to have some kind of revival. So and part of this is about patient selection. Just explain us, the patient you got in front of you now, why does he qualify compared to some of the patient who was treated early on?
Yeah, so that's a very good question, Lars. So what we have is, we are one of the centers in the Netherlands that really has continued its program over the past decade, actually. And obviously, after the results of HTN3, things collapsed a little bit. But what happened is that we still kept on getting referrals, and we kept on being involved in all these large pivotal trials. So that was Radiance, that was Radiance Trio, Radiance Solo, that was HTN on-med, off-med. So all trials that had a very meticulous trial design designed in order to exclude all the biases that we've learned from the past, really jeopardize the potential of demonstrating any blood pressure lowering effect. So that said, I mean, for Radiance, for Trio, for on-med, patients needed to fulfill very strict in- and exclusion criteria. And this patient, for instance, did not meet any of the study criteria because he could not be put on standardized triple therapy. And conversely, his blood pressures were too high for an off-med trial. So there are a lot of patients who fall into these two categories of trials we're running at the moment. But conversely, we've learned that in these strict settings, the therapy works. So off-med as well as on-med in a fixed triple pill combination setting, RDN lowers blood pressure significantly. So with that, I mean, these patients still have their symptoms, they have their end organ damage, risk for long-term complications. So we still give them now and then the chance to get a procedure. And as today, we do still a handful of cases per quarter.
No, really good. So let's take us through your procedure. It'd be nice to see.
Yeah, excellent. So maybe we can go back to the slide. So we obtained, for as we do for each RDN, we do our echo-guided common femoral artery access per routine practice. This procedure we will do with the Record technology, which needs a 7 French sheet. So that's what we did. We made a pictal aortogram. Then we do a selective angiogram with, in this case, a 7 French guide, either EMA or RDC curve. Pre-denervation will give some conscious sedation. We typically do that with some midazolam and fentanyl up to 100 micrograms. And in this case, we'll use the RDN system of Recor. So maybe we can briefly show that to you. So this is the system, 2 key components. One is the Paradise catheter, which is a balloon-based device over the wire with a ultrasound emitter in the middle that allows circumferential energy transmission, which is unique to this technology. Centered in a balloon that allows fluid passing through the ultrasound element in order to cool the vessel wall. And then there is the Paradise generator, which we'll demonstrate to you live in a second. Next. So this is just how the catheter looks. If you would put it in a bowl of water, you can see the ultrasound waves really in the water. The good thing, another good thing about the treatment is that it's very short. It's only emissions of 6 seconds per artery. Next. And here is a gel model. So you see the balloon here in a gel model. When it's put on, you can see that this gel turns color once it gets to a certain temperature. In this case, it's around, I think, 70 degrees. You see how fast it goes. You can see that here in another direction. You see the gel turning color, turning white once the balloon heats the tissue. And you can also nicely see that just surrounding the balloon, where you now see the blue lighting up, there's no heating. So meaning that the cooling flow in the balloon is actually working to preserve the vessel wall. So that, in a nutshell, is the technology we want to use today. And then the key thing is the sizing. But before we go to that, we maybe show you what we've done so far. So if we can go to the angiogram, we always start with the CT scan in order to get the impression of the renal artery anatomy. I think that's crucial to identify if this patient is amenable to the therapy. In case there is renal artery disease, you obviously don't want to treat these patients. So we start with the renal artery angiogram in order to get a good impression of the takeoff of the renals. It's typically at lumbar 1, so you see the lowest rib. You go one level down onto lumbar 1, and then you usually have the takeoff of the renals. In this case, they're a bit lower and also have a quite steep takeoff. Then we made a selective renal angiogram on the left side and on the right side, demonstrating us these are nice solitary renals, no accessories, and a length that allows at least 2 ultrasound emissions in the main branch, because that is with this technology what we are aiming for, is to do 2 ablations or emissions in the main branch, which makes that you need at least 2 centimeters of length before the first bifurcation. With this technology, given the circumferential denervation or ablation, there's no need to go in the side branches. But obviously, there's still a lot to talk about treatment strategies. If we go to the QVA we just made, you can see here on the left side that the diameters are approximately 6 to 6.7 millimeters. And if you would put that on top of the sizing chart, which allows treatment of arteries between 3 and 8 millimeters, we in this case would opt for a 7 millimeter balloon. And that's exactly what we've prepared just now. So maybe if we can show the catheter live. I think it's nice to demonstrate.
Just to clarify, so
this
for
is
a 6 millimeter artery,
yeah.
For a 6.5 millimeter artery, you choose your oversizing a little bit. What's the reason for that?
Yes, you oversize a little bit, and if you go, maybe Rakesh can show you the sizing chart. The key thing is that you want complete occlusion of the vessel wall. That is actually the key thing you want to achieve, because you don't want the balloon to move. Plus, you want the cooling to be efficacious, and for that you need a certain level of wall contact. And as you can see, the oversizing is very limited, but in some cases you slightly oversize. But that, in all the studies we've done so far, in arteries that we at least screen as being healthy, has shown to be very safe and did not cause any significant dissections or hematomas in any of the cases that we've done.
Okay.
Does that make sense?
Yes, a lot. Go ahead.
Okay, good. Back to the catheter. So this is the RDN catheter. It's a over-the-wire device with 2 flushing ports at the end that go into the Paradise generator that automatically flushes and prepares the device. At the end, the lumen for the guide wire, and here on the tip, the balloon. So that's it. No rocket science in terms of things you've seen thus far, but a technology that really has developed over the last couple of years with expanding balloon ranges and a really quicker procedure. Initially, I think it was something like 20 or 30 seconds. Now it's just ablations of around 6 seconds per position, which makes this technology quite appealing.
But this is an 014 wire, Jules?
Yeah, so we engage the renal artery here on the left side with the RDC catheter. So we usually do all our cases either with a EMA or RDC. In this case, we took a RDC. There was quite some tortuosity in the groin, so we took a long sheet in this case, a long braided sheet. And then you need a guide wire. I think that is crucial to beetje uitlopen. Remember, in this case, we need a little bit of support, so we usually use a non-hydrophilic wire. We use a BHW in this case, which is quite atraumatic and gives you a bit more support than for instance, a BMW or something in that range. Yeah. So we're now engaging the catheter through the 7 French sheet. So it's over the wire, so Wendland is fixing the wire. It's always a little bit of a game between the 2 operators, depending on how much support you have. So here, given the tortuosity in the groin, it might become a little bit tricky. It's a 7mm balloon that obviously has a somewhat larger profile than a 4 or 5.
But Joost, if I recall well from the past, in the past, there was no coronary wire. There was no wire involved, was it? Was it always over the wire? No.
So we've used multiple technologies here. The St. Jude technology in the past, was indeed a technology that was you could do that all without the wire. But the Medtronic technology, for instance, always required the use of a wire. In order to deliver the device. Also, the VASIC system, I think, is something that for which we needed a wire. So let's try this again. Nicholas, you remember the first live case we've ever did with this technology?
I must have.
You have a small blackout. Yeah, you better have that for that case, because that was a case in which we failed to engage the renals in a patient with a BMI of 40 or something. Do you remember?
I have a selective memory.
So when do you start seeing the therapeutic response after this therapy? And is it different from one device versus the other?
No, it's not, Roxanne. So we typically see all our patients back in a protocolized way at 1 month, 3 months, 6 months, and 1 year, and then yearly up until 5 years. And if they respond, and 70% of patients do, we see them back at 1 month, and then typically already see a result. But most trials have picked their endpoint at 3 to 6 months. And then in most patients, if there is a result, you see that at 1 to 3 months at least.
But that's one of the issues, right, Jules? Because there is nothing you can monitor during the procedure.
No. That's absolutely correct. Yeah. So I'm really having difficulties here in getting this catheter through the catheter. I have to admit that in most patients we've done, the past years, it went quite smoothly.
Do you guys use this in Atlanta? Kendra?
Sorry. Yes, we do have one operator who's very interested in renal denervation. And so we are investigating with the various trials this. I, of course, don't participate in this procedure. But I will say I was very impressed with the anatomy. And one of the things I found so interesting was that we do similar things when we're trying to decide on TVARs and EVARs and some of the challenges of the system and placement of the balloon. I think this is a good example, and so it'll be interesting to see how he troubleshoots this.
Yeah, we're watching.
Yeah, so the key thing is good guide support. So now we're in, that's good. I think we're already good because we don't want to go too deep. So the balloon, I think the ultrasound element is 6 or 8 millimeters in length. So that's the radiopaque part you see. Whereas the balloon is 1 millimeter. So that allows you 2 emissions at both sides of the artery. We'll give a little bit of contrast in order to check the position, Reinhold. I want to stay in front of the bifurcation. Yeah. Right, so let's see that the catheter is almost occlusive. Test. Good test. Yeah, okay, so I think this is good. Alrighty. So with that, I think we'll store this, and we'll prep the balloon. So if you look at the generator, we inflate the balloon. All right, so the balloon is inflated. We'll now give a little bit of contrast. So the nurse is now telling the patient he might feel some pain in the left, just in a minute. Test. Yeah, okay, so we nicely see that the position, you see the very small accessory just on top. So we're just behind that, and that's exactly where we want it to be, just before the bifurcation. So with that, we can start the sonication process. Store. Takes exactly 6 seconds. So first the cooling starts. So maybe we can show, you have to, yeah. So the 2 consoles you see are the tubes in which the sterile water circulates to cool the balloon. So that's it. 60 seconds. The system automatically deflates the balloon. And then we're good to go to the second position. Pull back a little bit the...
Wow, incredible.
Yeah, so this is probably not the most sexy procedure you've ever seen, but
yeah,
it's nice. It works nice, and at the end, the goal is not the procedure. Great. The goal is that it helps.
It's great to see this back, and if it's okay with you, we're going to go over to Leipzig. But you're doing one more treatment on the same side, is that right?
Yeah, so we do 2. We'll check again whether the balloon is occlusive. Yes, it is. So I might want to go a little bit back, so deflate. We'll do one more, and then we'll go to the other side. So if you want to switch to Philip, that's absolutely fine.
Yeah.
I think we've demonstrated the critical components of what we wanted to show you.
Fantastic. It's just great to kind of have renal denervation back in the news again. So thanks for that, and let's go to Leipzig.
Very good. Perfect, thank you. Inflate.
Hi, Philip.
Welcome
We're back to you again.
Yes, you're right in time to see with us together the closing of the second Pascal ACE device on a transgastric view. Again, antroceptally positioned. Christian will close now. We watch the leaflets, the device, and hopefully we'll also be able to appreciate that the anatomy is coming closer together. Okay,
fully closed.
Good.
Yeah, that's
we
for
did
sure.
That in a breath hold.
So
Good. We go on breathing again. And then we have a little bit time, and we can also show you what we've done. But we wanted to show that live, and we were still within the same breath hold. Okay.
Well, it's interesting because, I mean, with your first device, it almost looks like you already reduced the TR quite well, no?
Yes, we did. So maybe we go, let's have another color here. Okay, that's certainly better. Okay, then we go to, can we go back and show what we've done? So as said, we weren't happy with the first grasping attempt and thought that we have to improve that a little bit. So this was then the position of the second attempt with the first device. We had to work a lot with transgastric because it was really difficult to get grasping views. And this was then, is that after closure already?
That is actually the closure.
This is
closely after
closure?
closure, yeah.
Yeah.
This is the actual closure, and the next slide is, next loop is the closure, after closure.
Okay, go to the next. Again, you see here that the anatomy is coming closer together, the two leaflets. And here it's also, I think, pretty easy to appreciate that both leaflets are in. They get limited in motion, which is a good sign that we have enough leaflet in. Okay, so that was after the first device.
This was the color result after the first Pascal.
Obviously still central. But if you compare the amount of TR after this one and then after the second, you see that it was worth placing the second one. Okay, then let's go to let's show what it looked like after release. Oh, that was okay. Maybe we can we show fluoro, please?
Want to see live or the picture after release?
Okay, so that was after release, and this is a valve with very little tethering, as explained. Atrial TR, very dynamic. So what you see after release is that both leaflets are nicely in, but the device still moves a bit because we have a quite dynamic component, and that was the reason why we placed the second one. Okay. Then we can. Can you go forward, please? Because for the second device, we had a chance to confirm our position also on a mid-esophageal view. If we can show that.
Yeah.
So Philip, in terms of stability, is it also an argument to have a lower threshold, to add an additional Pascal device, just to prevent late dehiscence?
You mean a third one?
Yes.
No,
I understood that.
So that you would not stay with one.
Yeah, in an anatomy like this one, sorry.
Go ahead, Philip.
In an anatomy like this one, we strongly believe that it requires two devices for the reduction in TR, but also for long-term result for the stability and avoidance of late SLDA, as you said, Nicholas, exactly for the reasons. What I would like to share with you, so normally what we do is we confirm the amount of leaflet which is on the device, but because here it was more difficult, we couldn't do so. We had to rely on transgastric view and use more surrogates of good leaflet insertion. But here, before we went again transgastric with the second device, you can see that the septal leaflet is on the device. So that was quite reassuring.
David has a question. David?
Yeah, no, I was just amazed. I mean, it looks like such a great result so far. I mean, I haven't actually seen the color, but the alignment of the Pascal devices, you seem to do that effortlessly. It seems a terrific result. What I wanted to ask was, how with this technique, when you're transgastric, can you be sufficiently certain that you have enough tissue within the Pascal before you release it? It looked quite hard to me to see that you could really be certain.
Obviously, it's much easier when you have mid-esophageal views, but there's some surrogates like the appearance of the leaflet going in and out of the device, whether this is sort of a half circle or not. The restriction in motion once you have the leaflet on, and then most importantly, while closing the device, normally you get a good impression of how much leaflet you have in, because the way the leaflets are coming together, that's a good indication of how much leaflet you have in. And if you see that the two leaflets are coming together very nicely, then you're fine, and we haven't seen SLDA in these cases. Can we have a? Shall we look at color also on mid-esophageal? So we started off with torrential or with grade 4?
We start with torrential, yeah.
With
From
torrential.
the Aroa, actually torrential.
Shall we release? Or?
Yeah. But maybe another color here and then release.
Yeah, it's definitely reduced.
Not easy
That's
to see here,
amazing.
but
Not really. Not really comes through.
I think we can see quite well.
okay. Let's go to. Shall we go to transgastric because we don't see a lot here anyway, and then we release.
So I start to release.
I'm fascinated about how these two clips have brought there's like the annulus has kind of come together and it's a lot smaller than what we started out with. I'm really fascinated by that.
Yeah, I mean, that works in atrial TR, that works in moderate tethering, but it certainly does not work once you overcome a certain degree of tethering, then it's probably too late, and then it's more difficult. Okay, can we take off color for a second, please, and concentrate on the... Camille?
Keine color? Okay, no color.
Can you show again the line of coaptation with the leaflets being in?
But it's a huge structure. I think it can easily accommodate an additional 3rd Pascal if you would like. Although you already have a significant reduction, I would say.
Yeah, I mean, it doesn't seem that there's any
but-
need, does it? I mean, you've reduced it from torrential to moderate. Surely that's plenty.
Well, I think it's moderate to severe probably, but the gestalt of the valve changed completely. Huh? It really is the appearance is becoming different, and also the coaptation is improving, as Roxana already mentioned.
Camille, kannst du mal auf die Höhe der Koaptation gehen, bitte?
Was meinst du?
Coaptation.
Okay, looks good.
How often are you adding a 3rd for a patient like this?
Not too often. Not too often, to be completely honest. But let's assess the anatomy again.
Yeah, as we discussed in the
the,
beginning, taking it from torrential to moderate is even a win in this case.
I would say so, yes.
Camille, maybe we do another assessment and then come back in for the very last view in 5 minutes. Is that okay?
Yeah, no, that sounds fine to us. I think we're okay. We can go back to Erasmus for a second, but we could also stay with you if you like
good.
us.
Of course. Okay, maybe we focus again on that transgastric view and try to get it in a little bit better.
And Philip, do you find that as time goes on, once you've got this kind of result, you actually getting a further improvement in the TR with continued use of medications, the spironolactone, etc.? I mean, that's what I would imagine would happen.
Yes, and we would hope so, but that should not be an excuse not to try your best once you are in the cath lab. Camille, bisschen off, ne? Die Ebene, wir müssen.
But this evaluation process that is ongoing now is so important. You really have to interact with your imager, with the anesthesiologist, because there's so many factors that are interfering the interpretation of the TR that you're seeing now. And this is an important decision here. In the hands of Philip, I don't think it's a problem to add a 3rd Pascal. I mean, it's another 15 minutes, but obviously you don't want to do that if it's not necessary or if there would be no additional benefit. So this is now an important moment of evaluation.
Remember, though, every time you use a 3rd clip, the Edwards share price goes down even further.
But there's something to be said about now being able to manage this patient better with moderate TR and not, sometimes in an 87-year-old lady, less could be more here, and there could be some remodeling or almost almost quickly with the ability to be able to actually get around this by going from torrential to like down to moderate. I don't know what Philip is thinking, but he might be wanting to do more. I don't know. Philippe, tell us what's on your in your brains.
Still thinking.
I mean, it's quite hard to image, isn't it? We haven't really seen the color jet terribly well.
Well, you know, don't feel this is a pretty important decision. We don't want you to think like you have to make that decision immediately. We only have 3 more minutes anyway. But
so
it's been an incredible case.
Philip, to everyone, I mean, do you try to optimize the chance of the procedure, keeping the patient on the dry side before the patient's coming into the cath lab to have less coaptation gap between the leaflets? And will this also affect your assessment of the residual TR after grasping?
That's a great question.
Yeah. So in those with borderline gaps and in those with anatomies where we would think that treatment is not possible or it will be extremely hard, then we try to diurese them and see whether it's whether we get more favorable anatomies. The only risk here is that when you diurese a patient to a very unphysiological state, obviously at some point she will or he will have more volume on board, and then you have the risk of a unsatisfactory result or even the risk of an SLDA. So it can help in some cases, but you should not overdo it. Okay, so we made a decision. We will place a third, and maybe we can share with that you then in a different way in an hour's time. Okay.
Yes, because you will be in the panel in an hour from now. So maybe we can then.
Yes.
Maybe you can briefly show the final result. Then.
We would love to see that.
Definitely.
Thank you, Philippe, Christian. Fantastic case. Thank you so much. What a great case, both from you as well as from Justin Wenan. We saw a renal denervation case there with ReCore. It was fantastic. Thank you. Your expertise is widely appreciated. Thank you so much. I really want to say that, yeah, what a fantastic session we've had. I want to once again thank our amazing faculty over the last couple of hours with great sessions. Lars Sondergaard from Copenhagen, Nicholas Van Meegen from Erasmus, David Hildick-Smith from Brighton, UK, and Kendra Grubb from Atlanta, and of course our keynote speaker, Dr. Valentin Fuster. I want you all to stay tuned. Even though we're finishing the session, just note that there is a symposium coming up with Dr. Thomas Modine and Dr. Becky Hahn and Dr. David Wood, Dr. Victoria Delgado. I really want to tune into this on the main channel, as well as our final breakout session that's coming up streamed shortly after this on our via our secondary channel. So thank you and goodbye, and we'll see you soon. Bye-bye.